sounded like you were whispering.
Should be.
It
All
is.
right.
So you can show the picture of what you guys are doing and the screen.
All right.
Nobody else in here can understand.
Any questions on palpation that we covered last time? No? None? Solid? Give you back your proficiency form. I combined this score with the skill check off for ankle in Blackboard. So this score was added to the skill check off form that we did for ankle. Okay. So we got through palpation last time. We're going to continue on to functional. It's pretty easy for the knee. We have flexion and extension. There is some accessory motions. When you bend your knee to about 90 degrees, you can internally, externally rotate tibia. But we're not going to try to measure that. It's not something that is typically a problem in patients. You'll typically see limits in flexion or extension as opposed to rotation. So we'll have them actively flex, actively extend. We'll do a little passive overpressure. Get our endpoints. What should our endpoints be? Like extension, what should that end feel be? I got a hard, I got a couple firms. Anybody want to guess soft? Going once, going twice? No? Okay, that would be firm on extension. That's hamstrings, joint capsule, preventing hyperextension. What about flexion? What kind of feel? It could be soft, it could be firm, depending upon their build. And if they've got some fat-ass calves that are running into their hamstrings, that's soft tissue approximation. It doesn't have to be fat calves. They could be well-developed muscular calves. But if the calf muscle is running into the hamstring, that's going to limit the flexion there, and that's going to be soft. Otherwise, it'll be firm. Okay? We can do both of those with them laying prone. Right on the edge of the table. Put the knee off the edge. We can get full extension. Get subject up on the table. Can we use this one? Let's use this one so the camera catches it. Lay prone, please. And that way, knees just off the edge here. Okay, so I can do flex for me, bring it all the way up. I can do soft tissue approximation there, soft end feel for flexion. Extension, because there's padding on this table, I like to put my hand under it so I can feel that end point. Okay, so I got my extension with firm end feel. Same thing bilaterally. For goniometer, I'm going to line up the stable arm with the greater trochanter. So I'll find that greater trochanter. I'm going to line it up on the joint line. I'm going to line up the distal arm, the movable arm, with the lateral malleolus. To find that joint line, I'm going to have them flex, extend a little bit. I'm visualizing that spot. Relax. I'm going to measure in this position here. I can see if he has any hyperextension, which he's got just a little bit. He's got about 3 degrees of hyperextension. Flex for me, please. I stay on the lateral joint line. I make sure I'm at the greater trochanter. I make sure I'm with the lateral malleolus. He's got about 122 degrees of flexion. Okay? So it's pretty straightforward with goniometer. You're not going anywhere. Get comfy. So in that same position, I can do resistive. We'll start with flexion. Now, You'll see people measure flexion or resisted flexion seated, where they're on the end of the table, and they'll just come down. My concern with this is I hit the table, and I'm not at 120 degrees yet. So you'll see people do extension in this position too. Then they're starting essentially from 90 degrees. They're just getting the last 90 if they're doing it in the seated position. It's going to tell you the strength of the muscle. It's not cheating or anything like that. It's just not getting the full range of motion of the muscle. So in the prone position, the table's not in the way. We can now get the full range. I'm going to have him flex all the way up. What I need to do is try to isolate the medial muscles by internally rotating the foot. I'm going to try to isolate the lateral muscle, bicep femoris, by externally rotating the foot. Question is, where do I hold and where do I put my hands? You've got some small person here with little itty bitty legs. It's easy. You get somebody bigger and stronger, you get alignment. Their thighs are like my waist. They'll throw me across the room if I don't put myself in the right place. And yes, my waist is about their thighs. So.
Just body positivity.
Yeah, I'm okay with it. They're the ones with fat thighs. All right. So what I like to do is cross over for hamstring. I like to make sure I'm in a good solid position. I'm not going to slip off of the foot because if I do, he's going to kick me. I'm going to stabilize here. So he's externally rotated. I want you to bring your leg up. All right. Relax. Now internally rotated. Stabilize here. Bring your leg up. Okay. Relax. You can do it down here like this. Come up. My only concern is if I do slip off, it's going to pop me in the chin. So you got to make sure you put yourself in a mechanically advantageous position. When we get to hip, it's going to be even more important because we have even larger muscle mass moving the hip and a longer lever arm with the leg. For extension, once again, we need to be really careful and put ourselves in a good position. If I stand here and try to do an eccentric bicep contraction resisting his quads, who's going to win? Chances are he's going to win. I might even hurt myself in the process if I try to do all my resistance with my arm. Whereas if I stand like this and I lock my arm out, now he's got to overcome the weight of my body, my whole torso. But his leg's going to end up over here. So if I do this, now I'm straining my back. I'm kicking my hand. So what I like to do is I like to hold him in this position here. I want you to extend, please. And I walk with it. I take a step or two, however many it takes. I keep my arms straight so that I'm using my whole body for resistance, push, and I'm walking as I go out. Okay? So you've got to adjust depending upon the size of your athlete and your size. You put two small people together, hey, easy. If Kelly were up here on the table instead of on the computer, I could probably do an eccentric bicep and probably win that battle. Maybe not. Little cheerleaders, sure thing. Big volleyball players, I mean, that tibia is the size of my femur. Think about it. You got to match yourself and you got to be careful when you're doing this. We're getting into much bigger muscle mass. So let's break out with partners. Active, passive, resistive. We got laundry. Active, passive, then resistive. Slide down so your knees are up ahead. Right, just let it line for a second. See the hyperextension on this side that we don't have on this side? Gentlemen?
What?
What? You see a difference?
You too, don't you?
This one's hyperextending it quite a bit compared to this one.
Oh, yeah.
Let's measure that. Malleolus, root drug cancer. Let's get pick on it today, okay?
Is this surgery side, just looking for the joint mark? Half one is bigger on that side. Like when you look at it this way,
So would you say it's more like,
half is longer.
It gets to be, it's gonna be
Like right here.
proximal to the fibular head.
Just take a level. Is that
At least
appropriate
10.
clinician rated outcome measure? A level of their heels, but level across them.
so like 11
Sure.
degrees?
At 11. All right.
Sorry, where you got injured? So you've always had issues with that right leg.
He's like,
We just asked him to
torn your
get
ACL or anything before?
Not yet.
Not yet.
A year later.
How'd you tear it?
Flag football.
Dang flag
That's hardly
football.
worthy of it.
It was
you know?
like, it was the grass, nice one, please.
Slid?
Yeah,
You
like,
got
stuck
three
with that
plant
leg
turn?
blade, got caught, and someone did hit me.
What was this?
Like 4.
Okay. Active taxon resistant.
What was the difference?
This one was 4 degrees, this was 11.
Ooh.
You know, when you're using a goniometer like this that has the big circle, you want to make sure it's not running into the table. That's why we get them with the knee all the way off the edge. Because otherwise that adjusts where you can line up the axis.
So for, like, since she has hyperextension, do you start it? Or
Your measurement starts at 0. Your
Okay.
measurement for flexion and everything starts at 0.
Gotcha.
You can continue.
Okay, go ahead,
Like-
Nicholas.
Yeah, when we did grip measurements, he was off a little.
It was.
Steve Franz.
Yeah, like 2.5 or 3 centimeters.
Yeah. Okay, let's
What's that? He'll be on.
You're good. And this one's like 125. Same.
Push.
So,
Top hand. Top hand.
so
There you
pushing
go.
yourself a little even like here. No, like face the other way.
You in first. Is
Yeah.
it easier to cross or is it easier to cross?
Easier to cross.
Yeah.
Well, think about it. If you don't cross, you end up like this.
Yeah.
That's not a good place. So your resistance arm's gotta be on top so that it come across your body.
You're an internal routine.
Yeah, think of where you're gonna end up. He's gonna end up like this. You don't wanna be like this. want this hand on top so we can move across your body. Okay, resistance.
Externally rotate. Go ahead.
Not supposed to hurt yourself getting on it.
Function of age.
He is our oldest classmate. Yes. All great.
Externally
Salt and pepper look.
Externally.
Bring it up.
Oh, yeah, there you go.
Hold that one up.
That's right.
There's
You
no
already know, right? I don't believe it.
extension.
Switch hands. Alright, two muscle guys might be up now with power.
Sorry, but it's not.
No, just walk with it so you're not overloading your back.
There you go.
And then extend.
You like the front push.
I think I'm
Questions?
Find your landmarks, line them up.
Scoot down just a little more.
There you're good.
So very good.
We're getting out of that game, so to speak. As soon as we did, Tommy's getting this back. There is, but there's going to be a whole lot more variability. Streets that are the same year, like neighborhood.
Oh, you mean like the advising side?
No, that's the whole. When I started here, we had those professionals.
Oh, no, there's.
So this one doesn't have execution. This one's got meticulous.
I'm gonna do this one so we're good.
Okay.
No, not really.
So that's your stress here. Wake up.
Serious cost.
Leave it. Right. It's easy.
Yeah.
Okay, do I guess.
There's policy for that, well, there's exception. I can't legislate. which way.
Right.
What happens when this happens?
We're doing this sartorius.
We were flex. Rotate one way or the other.
We have to do.
Yeah, we're gonna try to isolate bicep femorums, semimembranous tendinosis, not just straight. That's more the medial membranosus tendinosis. All right, you move this hand up, so you're not preventing flexion. Oh, you put a little block. Okay, when you're doing resistive flexion and you're stabilizing, make sure your hand is not in the popliteal fossa, because that's just limiting their motion. Move your hand further up their thigh. Extension. If I'm worried about them being too strong, keep my arm straight. Therefore, I'm not doing any of this. All right. So the last one is this on the end of the table. The sartorius.
Always lots of traffic.
Sartorius flexes the knee, the hip. It does a little bit of abduction and external rotation. Essentially, when you do this motion, you're doing the sartorius. You put your foot on your opposite knee. ASIS, down to where?
Against the A.
Pes
Something.
and serene. Okay, so it comes right down across there. So it does this motion. We're going to resist that motion. I want you to run your shin or your heel up this shin, up to your knee. They're going to do that motion. Our resistance is not real hard here. Otherwise, they won't be able to move. It's not a big muscle. Go ahead. So I'm resisting here and here. Bilateral comparison. Bring it up. Pretty simple. Make sure you let them move, okay? Don't try to intimidate them. That's not cool. Give it a shot.
It's like 6 hours.
So resist here and here. That's sartorius.
Mine's weak.
All right. Any questions on range of motion? Pretty simple. Flexion, extension, active, passive, resistive, and then sartorius. Goniometer is really easy. Lateral joint line, greater trochanter, lateral malleolus. That's the easy part. Now we get to the fun part. Excited? Special tests. Oh, you got notes? You may want to write something down. I don't know. Maybe not. You don't have to. It's that photographic memory. So we're going to do valgus stress test at 0 and at 25 degrees. So in full extension, In full extension, we're getting everything. The MCL, medial joint capsule, and the medial meniscus. Medial meniscus is attached to the medial joint capsule. So when you sprain the MCL, you often tear the medial meniscus. But remember, we palpate that MCL all the way down onto the shaft of the tibia because there are different fibers that are tight in different positions. So when we take them to 25 degrees, now we're isolating the MCL. Just for ballpark, that's about 25 degrees. So we're going to do valgus at 0 and 25. 25 is just for the MCL. Like all of our ligamentous tests, we're looking for pain and laxity. It should be a nice firm infield. This is pretty good sensitivity. Over 80% is your threshold. That means those with the condition. We're going to do varus at 0 and 25, just like we did valgus. When we're at 0, just like with valgus, it's getting the LCL and the joint capsule. There's no attachment of the lateral joint or the LCL to the lateral meniscus, so that is not involved in this test. When we bend them to 25, we're getting the LCL. Doesn't have great sensitivity. It's extra articular. It's outside the joint capsule. A lot of people will report that infield is kind of springy on the LCL. It gives a little bit of a bounce because it's not part of the joint capsule itself. We have more MCL injuries than we do LCL injuries. Most people are a little more knock-kneed than bow-legged. And most forces of things we're doing result in a valgus stress. We have a couple tests for the PCL, posterior cruciate ligament. One is sag sign that has pretty good sensitivity and specificity. Those with the condition, those without, that's excellent, 100%. If they don't have a positive sag sign, that means they don't have a PCL tear. We also have Godfrey's is another PCL test. For sag sign, we're going to put them supine with their knees bent to 90 degrees. And we're going to look at the tibial tuberosity relative to the patella on each side. If they have a PCL tear, the tibia slides back relative to the femur. So it sags. And it's sag sign. Godfrey's, we're going to bring them up 90 degrees, 90 degrees. We're looking for the same thing. We're looking for the tibia to slide back relative to the femur. We have an anterior drawer test. This is for the ACL and the posterior capsule. This one does not have great sensitivity. This one's going to give you false positives periodically. We're putting them in the same position for anterior drawer that we do for the sag sign. Laying on their back, feet together, knees bent to 90 degrees. And in that position, the sag sign, we saw the tibia slide back relative to the femur. Well, we're putting them in the same position for the anterior drawer. But with anterior drawer, we're pulling forward. So if they have a PCL tear and it's already slid back, I come in and I apply an anterior force, I get that displacement. I got an ACL tear. No, you have a PCL tear. You have a positive sag sign. You're just bringing them back to neutral. So that's why the anterior drawer is not the best test for the ACL. The best test for the ACL is Lachman's. Very good sensitivity, excellent specificity. If there's one test you have to walk out of this class with, it's Lockman's. It's the gold standard for ACL tears. If you can't get this one right, I failed you as an instructor. Or you just failed as a student. You take it. We're going to bend them to about 20, 25 degrees. We're going to do an anterior force of the tibia relative to the femur. The ACL is designed to prevent an anterior translation of the tibia. So we're going to bend them to about 20 degrees. We're going to pull up on the tibia. We're going to push down on the femur. We're trying to get the two to separate. Okay? I'll show you a couple different ways to do it because hand strength is a big issue for Lockman's. Posterior drawer is the opposite of the anterior drawer. Same position, supine, knee bent to 90 degrees. Same position we do anterior drawer in, we do posterior drawer. This is also the position for sag sign. We're also going to do slocum drawer in that position. We can do several tests right there without them moving. For posterior drawer, we're going to push back on the tibia relative to the femur. Anterior drawer, we pull forward. Posterior drawer, we push back. Good sensitivity and specificity for this test. We have two tests. Well, we have several. For rotary instability. And no, I didn't spell it wrong. Rotatory, rotation. I don't know why that term is used. It sounds weird to me. Rotary instability is what you'll hear a lot. We have slocum drawer. Slocum drawer is an anterior drawer test with rotation. So for slocum drawer, I'm going to internally rotate the tibia, pull forward. I'm going to externally rotate the tibia, pull forward. It's the anterior drawer test, but with some rotation on the tibia. It's getting different parts of the capsule, the joint capsule, by rotating. A real easy rotary instability test is the crossover test. This one, you have them stand up, plant one foot, the injured leg, and then have them rotate. They rotate their entire body and keep that foot planted. They're trying to put rotation on the knee itself. Slocum drawer is testing posterior medial and posterior lateral capsule. Crossover is testing anterior lateral and anterior medial capsule. Stand up and you'll feel the crossover test. Stand up. All rise. You need a little space. Plant your right leg. Rotate behind you as far as you can. Keep that knee in place. Try not to fall. You're going to feel it more anterior medial. Cross in front. You're going to feel it more IT band and anterior lateral. So this is anterior medial joint capsule. Crossing in front is anterior lateral joint capsule. You feel those? Yes. Somebody with rotary instability, they are not going to like that test. They're going to go part way, they're going to feel it, and they're going to quickly take their weight off that leg. And they're going to look at you like, why did you ask me to do that? That reason? I wanted you to do a positive sign, I'm sorry. You may have burned your bridge with them, and they will never trust you again. But you will have gotten a positive sign. The last one we have for rotary instability is the pivot shift. This is a good test. I'm not good at it. I've never gotten a positive on a patient. I've only seen positives when they're under anesthesia. You can do all sorts of things to them when they're under anesthesia. Which you might have the gutter, that's not what I'm talking about. When they're unconscious before surgery, you'll often see surgeons do a few special tests on whatever joint they're testing just to confirm what it was they were thinking beforehand. I've seen pivot shifts be positive under anesthesia, whereas I've never been able to get one with an ACL tear, which is typically the rotary instability, on a cautious patient. That's just me. Don't allow my bias to prevent you from trying to do this test. But for this test, We're going to internally rotate the tibia. We're going to apply a valgus force. And at that point, if they have a rotary instability, the tibia will sublux on the femur. It'll come up. It's an anterior lateral subluxation. We then bring them into flexion across their body. And when we get to about 45 degrees of flexion, it pivots and shifts back into place. It reduces flexion. The medial condyle is longer than the lateral condyle, so the tibia can pivot around the medial condyle. All right? We have a couple meniscal tear tests. McMurray's is probably the most common or easily recognized. Not great sensitivity, but it is good specificity. Apley's compression is also for meniscal tears. Again, not great sensitivity. This is people with the condition, people without the condition, but the specificity is good. You've probably seen people where they're laying on their back and somebody's got their hand up on the joint. And they're working it around, doing circles and all sorts of crazy fun stuff. Who's that? Well, anyway, you made it a bad joke. Nobody else did. There's all sorts of different ways to do McMurray's. We're trying to get the meniscus that sit on the tibial plateau, and we're trying to pinch them between the tibia and the femur. So we're trying to work the joint around through flexion extension with valgus and varus force to pinch the meniscus. If they have a torn meniscus, it's going to get into the joint space, and it's going to cause a stop, a block, a pop, pain, perhaps. Okay? It's like putting something in the hinge on the door. Suddenly that hinge doesn't want to work. So you'll see several different methods for doing McMurray's. As long as you're getting flexion to extension, you're getting internal, external rotation in the tibia, you're getting some valgus and varus, you're probably going to do okay. I'll show you the method I like to use. You'll see other methods. As long as they're getting those forces at some point during their technique, it's going to work. Okay? Apley's compression is another one for meniscus. This one, we're going to put them prone, face down. We're going to bend their knee up to about 90 degrees, and now we're pushing the tibia into the femur, and we're grinding it. So once again, you've got that meniscus at the bottom of the tibia. We've got that meniscus sitting here, and this would shift back because we have roll and glide. So it'd be sitting right on top of the condyles. We're trying to grind it into those condyles. Okay? Apley's distraction is the opposite motion. We're doing compression, we're pushing down femur, the tibia into the femur. Distraction, we're going to lift up. We're going to stabilize the thigh, we're going to lift up on the lower leg. We're simply lifting straight up. If there's a meniscal tear, that's going to relieve pressure on the meniscus and might decrease their pain. But if they have a capsule sprain, LCL, MCL, or joint capsule, when I lift up, that stretches it, that increases pain. So you could get two positive signs there: decrease of pain for meniscus, increase of pain for joint capsule. And then we have two tests for joint effusion. One's the sweep test, one's palatable patella. The sweep test, we're going to push the swelling away from one side of the joint. We're sweeping along the skin, quickly back in the opposite direction. You look for a fluid wave. So I'm pushing it away from one side, pushing it back. If you see that little bump, palatable patella, we're going to kind of milk the joint, get all of the joint and swelling and effusion up underneath the patella, then we're going to tap on the patella. Normally the patella sits in the trochlear groove, bone to bone. If there's a joint effusion, it will float as we milk the joint. So when you tap on it, instead of feeling bone to bone, you'll feel it bounce up and down a little bit. Okay? How else do we look for joint effusion? Other than our eyeballs. Measure it. Girth measurements. Okay. Subject on this table. All jump at once. Now you're excited about the opportunity. All right, my bad. You had ACL on this one? So, any current knee issues? Not that you want to disclose? Nothing bad. So, valgus, that's a force going towards the midline. Varus is going away from the midline. Don't make the mistake of doing valgus here and then thinking this is valgus here. That's not, that's varus. Valgus is always towards the midline. Genu valgum is not cleats. Stabilize lower leg. This hand on the lateral side of the joint. I like to put my elbow against my hip. So now I can use my whole body instead of just trying to use my arm strength. I keep her at 0. I make sure she's relaxed. I'm pushing in with this hand. I'm pulling out with that. I'm trying to open up the medial side of the joint. At 0 is easy. The joint doesn't want to rotate. When we take them up to 25, now it wants to rotate. The whole leg does. I like to put their toes against my forearm here as I'm holding down here. That helps me control some of that rotation. If they have an ankle injury as well as a knee injury, they're not going to like this because I'm putting essentially a Clyders on their ankle at the same time to control that rotation. But same thing. I put my elbow into my hip, I hold her at 20. I let that rotation happen, and once I feel the rotation stop, then I apply the force. Does that hurt?
No.
You all right? Just don't like people touching you? Relax. Toes on my forearm, control the rotation, then apply the force. You expect a nice firm end feel on these. So that's valgus. Varus, relax. 0 and 20. Once again, she's going to rotate. So I let that rotation stop. Now I apply the force to the joint. So I end up pushing down a little bit because it rotated out. Varus at 0. Relax. I didn't get to the subject here, did I? No, I really did. All right, that's valgus and varus, 0 and 25. Any questions on those? Sag sign. Bend both knees to 90 degrees, put the feet together. Okay. Now, I don't compare this one to that one because they may have a leg length issue going on They may have pelvic rotation, makes this one stick out further. This femur looks a little longer. I'm looking at the tibial tuberosity and the patella on each leg. If she has a PCL tear, this tibia is going to slide back relative to the femur. So I'm looking at that distinction. Does it look the same over here as it does here? If so, that's a negative. Godfrey's, relax. Okay. Godfrey's, hips at 90, knees at 90. The challenge here is, can you support the weight of their legs? And while you support the weight of their legs, can you get a good perspective on it? If you can't, put something on the table. Lift up. Down. Slide down that way. You just want their feet on it. Relax. So now I've got something to support it. Now I can get a good perspective on it, because I've got to be down at that level to once again look at the tibia relative to the patella. If she has a PCL tear, we would expect to see this displacement. So I'm looking at it on this leg, I'm looking at it on that leg. Put something up on the table if you need to. So that's sag sign and Godfrey's. We're just going to do the first half of this, and then we'll practice. Anterior drawer. So with their foot in the same position we did for sag sign, I want to pull forward on the tibia, and the femur's going to stay there. I need to stabilize the foot by sitting on her toes. Don't put them at the edge of the table with their toes hanging over the edge. Sit on their foot and break a metatarsal. You're going to look stupid if you break their foot. Came in for a knee injury, you leave with a foot injury. Get your fingers into the popliteal fossa. Your thumbs on the tibial tuberosity. You can feel the hamstring tendons. They should be relaxed. Pull forward. 2-3 times most. Okay? Looking for an anterior displacement. So what happens if they have a positive sag sign here? It's already posterior displaced. I pull forward, I feel that anterior displacement. Oh, I got an ACL tear. I got a sag sign that I didn't observe for. I got a false positive for an ACL. Okay, just be careful. That's anterior drawer. We'll go ahead and show posterior drawer. Same thing, but now we're just pushing back, looking for a posterior displacement with posterior drawer. Slocum. This is for rotary instability. The only thing I'm going to do different is positioning the foot. When I externally rotate the tibia, I'm now stressing the posterior medial capsule. Same hand placement, pull forward. When I internally rotate the foot, I'm now stressing the posterior lateral capsule. Same hand placement, pull forward. Okay? Finally, Lachman's. Then we'll come to the rest of the tests. The traditional Lachman's, relax, is holding the femur with one hand, the tibia with the other hand, with the knee bent to 20 degrees. I'm not going to be able to do this. My left hand is not as strong as my right hand. I tore my triangular fibrocartilage. This hand just doesn't have the strength. Alternatively, if I put my leg under here, I've got her bent to 20 degrees. Now all I have to do is push down here to keep the femur in the same place. I still have to be able to grab the tibia and pull forward. Okay? So all we're doing here is pulling up on the tibia. We're looking for that anterior displacement of the tibia relative to the femur. Now, if you see this motion, you're not doing it right. The foot shouldn't be wiggling off the table. Your pressure needs to be proximal tibia. Think of the tibial plateau. I need to be back here with my hand so that when I pull forward, I'm just moving the tibia. I'm not trying to lift the whole lower leg. So get them up on your leg, stabilize here, get back in the popliteal fossa. I'm like right over the top of the gastroc. I'm pulling up on the tibia. If you're really having trouble, the foot's wiggling, stabilize it with your elbow. Gets a little harder to do the anterior force because you're not pulling straight up anymore, but you're at least stabilizing the foot so it's not wiggling around. So traditional is this way. If I have somebody with small legs, I can do it just holding them. Most of the time, you're going to see me do it this way. There's one other method for this. You slide down on your stomach with your knees off the head. The same position we had her in for testing range of motion. My concern with this one is we have a padded table. So when I push down, I bend her to 20 degrees, I push down like this, I'm getting padding of the table movement here. If it was a nice rigid table, it'd be a little bit better. But even at the same time, she's got a good sized quad, so there's some soft tissue movement there. So you've got to push until you feel all that soft tissue movement is done. So now I apply that force to the joint, looking for an anterior displacement of the tibia relative to the femur. It's just reversing it, making it a little easier for my hand placement. Okay? So try any one of those three. That's okay. You can bring cookies tomorrow. All right? Questions? Let's try those with a partner. Start with valgus and varus. Which is at least that hard. Okay? Make sure you push at least that hard. What did you feel like?
For a little bit softer on the leaves. Yeah.
For Julie, it's soft. Ankle. There you go. Elbow against your hip. Put it in your hips. Now you can use your whole body to apply that force.
That much longer? Or do I have to get this?
So 0, now 20. 25.
Yeah, that's cool.
So it's good.
Alright,
25. It's going to come
Alright.
that way. So let it come that way.
Last time I had these, that's something I wasn't like that.
Are they pushing hard enough?
Oh, Lord.
Come on, guys.
Okay, gotta make it.
Which one are we on?
The varus.
You do bilateral and valgus. Cheating your patient. Practice bilateral. Oh, that's a funky hand placement there. It doesn't look very funny if you do it that way.
On the outside, that would be.
Put yourself on the inside. You'll see it done that way. I'm not saying it's wrong. It's just, it looks funky. I've seen physicians do it right here. Do valgus and varus like this. It works. I've seen them use the edge of the table, slide over to the edge. Seen them use the edge of the table as the fulcrum. That's varus right there. You're welcome. She's just not enjoying this.
So, you'll find out the little
Yeah.
tricks like Dr. Parr says.
We can switch this way.
Let it force, let it go, let it come back. He's pretty rock solid there.
Ferris?
Yeah. You'll feel that.
He's got a nice little tip.
It springs back almost, but you gotta let it come back to normal position. He's just rock solid
Yeah.
at 0 degrees, so it's hard to get that feel.
Don't do it.
Grip underneath, so That way you can control it.
You were about to. It looked like you were about to just fire us. You, the first thing is like that. Alex is out. So I am
I'm gonna be very afraid
please. That's what.
One thing
You see it at the table if you want. There's Barrett Sags things just on. But yeah, put the force vector from the inside out.
What is it? There you go. So if you're not kind of controlling that twist,
I mean, I know I can put the chair up.
She's not relaxed. It just be, I want to make sure you understand, if she isn't relaxed, it won't sag.
Yeah.
Okay.
feel that? Yeah. That's different than this.
Bilateral. Do it again.
Thank you.
So confused at this point.
There you go. There's Barrett.
That's fair.
Yep.
Fabulous.
That's values. Just do me a favor, don't reach across and pull towards you.
Okay.
This is lazy. It probably works. You're probably getting the right force on the joint in the right position. It just wants to
Was it like this? Like for
It's
instance,
not-
you have to feel like.
get the cool
If
kids
they
don't do
actually
that.
have a laxity, right, like if you pull,
It's not.
yeah, it's gonna torque it more, where it's here, you can, yeah,
So just put your butt cheeks.
okay.
And then you could, you don't have to crush it, but you just keep it.
Worked hard over there.
In my eval class, my teacher misspelled shift. Shit test, so I can't hear anything else.
Just stuck with you.
Test. Happens in my PT, CT, JT class. Spell.
So yeah, nothing more important about
Really?
Now, the other one,
Other leg,
there you go.
under the feet, under here.
down here. No, but the
You want him to relax his leg. But you want this free.
Stack that.
Touch me.
up there or down.
There you go.
Try to.
I'd like you to do this one.
We will. Double sided.
No, I was wondering if they were doing this. Downstairs. I was looking, I was like, oh.
Anybody else not get a double sided handout?
He's just done very awesome.
Yeah.
What are you looking for on that? What test was it? What are they looking for on it?
And your left on top.
Looking for
So
what?
you're reaching around.
Was like,
And getting right there.
Shift. Posterior shift.
Feels very stable.
So if you get a positive stack time, basically just should
Compared to, let's see,
doing Walkman?
Wasting
Yeah.
time. If you have a positive sag, you can get a positive anterior door, but it's not the ACL
I'm doing that too.
because of posterior capsule
You
PCL.
have to do this. Do it that way, but I don't think it's a little.
Teaching a little extra marcation.
As long as the knees at 20, I don't care where it's facing.
That's weird.
I like it. This one's easiest for me. So all I have to do is. find orthopedic surgeons have super strong hands.
Yeah. McMurray's specifically, that you have stronger hands, McMurray's is much easier.
Opposite hip, under his thigh. There you go. Grab the tibia. Foot should block. So all your force. There you go. Good.
Here.
You're doing interior, first or if you want to be like a.
What? Fear of performing them?
Get your.
Oh, of getting them done to you?
So once you've worked through those, switch around and try different legs.
Let's lock down and give her a little bit of flexion.
Do you feel anything? Not really.
So, one thing that I kind of see is that
You just gotta get her to relax and kind of didn't have a tendency to.
Because here's what I see. Let's see if it works.
It's also we're having
Two, sorry, I'm distracting, you're like guarding the info.
There's pressure.
Yeah.
Through there. So it's a little
Of course,
different than
trying to stabilize.
leg and free flow.
Got it?
You feel that
Oh,
different.
pushing that hard?
This doesn't take.
Maybe
much
it's where
effort.
you're pushing it.
Yeah.
I feel like his might have been lower.
It's like, yeah, right on the joint line.
Because I can feel this one. Like,
It's technique. But I have
Yeah.
someone that heals.
Put your elbow
does
against your
when
hip.
I look, it almost like puts pressure on the long axis. So it's more of that.
This is stabilized.
Relax.
Here's your full.
Get that lead. Yep. Relax.
Keep in mind, everybody has different amounts of accessory motion. That's why Dr. Carr wants you to test different people, because with very little accessory motion, you just not, it's going to feel different than that person that has a lot of joint glide naturally.
Feel that little pop up.
Yeah, it
It's
more so.
sorry. Didn't hear.
Especially more hard, but
long axis
Yeah.
pressure.
Nice.
It's so hard trying to like relax.
back.
That one seems.
Yeah.
Like you
And then,
Kind of back off your leg a little bit so his leg can come down. If your hands are big enough to get your thumb up to the front, do so.
Tucks in there.
If not, you've got to
Believe
keep
me,
it in the back.
that looks easier or shows up.
If you can grab that tibia, grab it.
But sometimes that's what she does.
Try some different legs.
little bit MCL. Yeah, he's just a mean dude. I see.
Have any of you seen any ACL tears with your teams yet? This year?
MCL versus team.
MCL?
Well, that's a big thought.
Right. No ACLs?
Yeah, ACL already, it was.
Okay.
Just had surgery this past week.
Too late.
Do you want us to do a test on it?
Yeah, I want you to feel positive alignments. It's an eye-opening experience.
You see him come back from surgery, see if you can do a ball full patella or sleep test.
Your own. When I tore my ACL, I was getting treated by a physician at UCLA. So he would come in with med students. And they would all take turns doing tests on
I
my
would
knee.
not be good at that.
No, you wouldn't. One of them, I had a torn meniscus at this point. This was a year after the tear. And the tear would get into the joint and block the joint. And one of these students was doing McMurray's and got it blocked and couldn't unlock it. So that student turned pale white in front of all their peers. The doc came in, he tried to get it back. Finally, the only thing, I would wake up and be out of place. I'd have to stand up and just force it and pop and go back.
Wait, what?
Torn meniscus. The student got it out of place and couldn't get it back. So that made that student feel pretty shitty in front of all their peers and the doctor and the patient.
Mel Gibson reduction technique. Huh?
Exactly, just slam it into the wall. Yeah, it didn't feel good. But, I mean, my joint was locked. I would periodically, I'd wake up and it would be locked. I'd have to get out of bed. Yeah, it was getting worse and worse.
That was my first surgery.
Before surgery.
Oh,
Pre-surgery.
Pre-surgery
I tore it in
for
high
ACL.
school. They braced it and didn't repair it.
Your meniscus,
ACL.
ACL.
Yeah. Didn't repair it, put me in a brace. And over the course of the first half of my freshman year, I continued to do damage.
Yeah.
So when's your knee replacement scheduled?
No time soon, it doesn't hurt now. Though periodically, there's a they tighten the LCL with the screw and washer on the outside. See it on the X-ray?
Yeah.
There's metal in there.
Yeah.
But periodically, it catches my IT vein. And it burns. I'll be doing something like this, go to stand up, and it catches for a couple of hours. It just
Surely they can take that out.
Do something.
so what
File it down so it's not catching.
that would require surgery.
Yeah.
I'll pass on that.
Well, nowadays, they don't even put you under. My mom got a meniscectomy in office in the Summit. He's a physician who, it's a local intercapsular anesthetic. They went in, she watched on the screen. He cut out her meniscus. That was 4 weeks ago.
That's pretty cool. Pretty soon they'll be doing that at halftime.
Mhm.
Did they tell you you had partial, like, tear?
What's that?
What were your original dates? You have partial tear? That's why you're.
No, initially it was just the ACL, but then I continued to lead an active lifestyle. I was young, and I ended up tearing the lateral meniscus and the LCL because the whole joint was unstable without the ACL. Switched around, worked on these on a couple other legs. Some people can live without an ACL. They can compensate. I had a football player at San Diego State that tore his ACL and didn't get it repaired.
Or when you're older,
The problem
like older populations, if you're not that physically reactive, they will not repair. We've had some patients in our NATA grant that they're 65, they just don't repair it. The risk of going under is greater than the benefits of repairing it.
Try some different. Somebody. You'll get me.
Yeah, right?
Hey.
Well, the guy.
Alright, I'll
Yeah.
Yeah.
For his grandkid's birthday.
Yes.
They didn't have the repair.
Yeah.
Like, no. Everything's just kind of.
Everything's tight.
It would flip it, yeah. Oh, sure. So the landing on a muddy hill, what do? Here's these days.
I don't know why.
So you're gonna put your board over here to put me in the front.
Okay.
They're just so uncommon.
Yeah. That's the one I just did that. Turned around and I was like, freak. Wait a second. I don't know why. He's going the other way.
It's
Right
stuck.
on, like horse.
Because we haven't covered it yet.
Okay.
Finish it, usually rotate these forks.
Just feel the blood.
It's supposed to look like that.
No, extension,
Yeah,
get anterior lateral,
I was a
stuff like
student,
that.
undergrad in New
That's
York,
what I
had
did.
hurdler. Come over and his back foot caught the hurdle and he landed on the ground and it was like, gone. That you could, in that they were videotaping it. You could see it just.
Yeah.
You did all those?
I didn't do safety first.
No.
Guy that was catching, grabbed his back.
Place your knee on my thigh. Use your, yeah, what?
You're not having a handshake. Do you tear LCL? Or
They call it.
with ACL and LCL? Which is not.
All right, so next time we'll cover the second half of that page of tests. You need to be practicing these tests on your own. If you, by chance, come across such a terrible situation where one of your patients has an ACL tear, or terrible situation, it never happens, take advantage of that situation and do a Lachman's.
Okay.
Okay?
Just sitting there.
Can we hurt you? Like,
You got a lot of things that pop, don't you?
yeah, do.
Maybe short notes.
It's hamstrings. Is that what's popping right there?
Now it's moving to you.
Oh, your ITV.
This is IT, but his hamstrings popping too. Yeah, sure.
When you're doing manual walking.
Mobility,
I'm guessing it
Something obviously, or the marathon. Okay, is it, take it off the table?
Yeah. The gracilis or the semitendinosus?
Must be the semitendinosus, fibrosis.
And then you pull up. I don't know if that's a normal one or.
What was the other way that
We'll probably do some soft tissue.
You're
Try needle.
Bend it to 20 degrees.
Try needle it.
Apply an anterior force to the tibia relative to the femur.
I think I'm more lucky that I don't have.
It's just, it's a little harder to detect the translation because now you can't see it. Normally with them
Sore,
supine, when you do that motion, you'll actually see that displacement as well as feel it, but now you can't see it anymore because it's going away from you. So it's a little harder to perceive.
Oh, you may stop recording.
Yeah, we're just,
Bye, Kelly.
as they were talking.
Enjoy the recordings. I think she could have been live, but I'm assuming she had.
Water bombs.
Sick baby, there's no telling.